Good evening. I'm Tony Segreto, the moderator for tonight's In the Know Town Hall. We welcome you to another important exchange with our preeminent UHealth experts. Tonight's spotlight is on inflammatory bowel diseases, a disorder that's impacting a large and growing number of people. Our panelists represent the Miller School of Medicine's Division of Digestive Health and Liver Diseases and the University of Miami's Crohn's and Colitis Center, a facility bringing the latest treatments and services to the IBD patients and their families all in one location. Inflammatory bowel diseases, or IBD, such as Crohn's disease and ulcerative colitis, almost affect 3 million adults in the United States. The emotional and physical toll is substantial as patients grapple with challenges and stigma of managing symptoms, flare-ups, and impact on personal relationships as well. Thankfully, we have an incredible team of UHealth and Miller School of Medicine physicians and researchers who are working tirelessly to find IBD cures and to ensure patients can better manage their symptoms. Now, before we get into tonight's conversation, after our opening remarks, the panelists will answer your questions that you submitted over the last few days. You can also submit questions during the program. Please use the Q&A feature at the bottom of your screen. And remember, the questions are submitted anonymously. We will get to them as many of them as we can. Now, it is my pleasure to introduce Dr. Amar Deshpande. Dr. Deshpande is the Associate Dean for Medical Education, Professor of Medicine, Division of Digestive Health and Liver Diseases, and Faculty Advisor to the Mitchell-Wolfson Senior Development Center. Welcome, Dr. Deshpande. We welcome you.
Thank you, Tony. It's an honor to open for my colleagues who are part of an elite group of experts. As Tony mentioned, inflammatory bowel diseases, or IBD, are very disruptive and take a large toll on the several million Americans, both directly affected and on society overall. The profound impact on daily life underscores the urgent need for comprehensive support systems, increased awareness, and advancements in medical research. Our work brings together the teams that can dedicate their time and talent to understanding, preventing, treating, and hopefully one day curing IBD. The Crohn's and Colitis Center here at the University of Miami started over 10 years ago under the leadership of Maria Abreu, and of which we have proudly been a part since its inception, is a product of this mission. You will hear about cutting-edge clinical and basic research, the impact on our diverse communities, and our advanced prevention and treatment solutions that are bringing hope to IBD patients. I'm thrilled to welcome my colleagues, Dr. Oriana Damas, Associate Professor of Medicine in our Division of Digestive Health and Liver Diseases, and Director of Translational Studies at our Crohn's and Colitis Center. Her work has been instrumental in better understanding IBD, as she has conducted incredible and translational research in understanding the dietary and environmental factors, as well as genetic roles that contribute to IBD, with a specific focus on our Hispanic community. Also joining us is Dr. David Kerman, Associate Professor of Clinical Medicine in our Division of Digestive Health and Liver Diseases. He is also the Chief Medical Officer for our Department of Medicine and is actively involved in numerous clinical research efforts, including as our site's lead investigator for many of the trials in which we participate for patients for whom conventional therapy has not worked. It goes without saying that a generous support from visionary donors strengthens and accelerates our groundbreaking endeavors, leading to healthier and more productive lives for our IBD patients, and to whom we are incredibly grateful. Thank you for your generosity and for being with us here today. Tony, back to you.
Thank you, Dr. Deshpande, for setting the stage. We move now to our Q&A portion of the event. And Dr. Kerman, we welcome you. Is there a cure for colitis or only a means to control the disease?
Thank you very much, Tony. It's an honor to be here with my colleagues. It's an honor to be here helping answer some of these questions. You started me out with a doozy, and the answer, I'll give you the answer that I tell all my patients, is that patients living with Crohn's and ulcerative colitis can live completely normal and healthy lives as long as it's managed. Do we have a cure? There are treatments that will control the disease. There are surgeries that can get rid of colitis, but there is not necessarily a cure that would completely get rid of it. Once somebody has Crohn's or ulcerative colitis, they have that for the rest of their lives. And as I said, the rest of their lives can be completely healthy, productive, no different than anybody else, not necessarily living with Crohn's and ulcerative colitis.
Thank you, Doctor. Dr. Damas, can you tell us a little bit more about what are the factors that contribute to development of IBD in new and emerging populations? And what can you tell families living with IBD about the disease, prevention for their children and relatives based on your studies?
Thank you, Tony, and I'm happy to be here today. And I see many people already in the audience that have signed in. I think this is a wonderful event. I think that to answer your question, and there's two, right? One of them is a very important one because we're seeing, as you mentioned earlier, that there's an increase in IBD throughout the United States and throughout the world, really. And what we were taught, for example, in medical school is that IBD occurred primarily in people that were European or white populations. But what we're seeing in South Florida and across many different countries, developing countries, is that IBD is becoming more and more common. And so to answer the part about environment, right, because is it really the environment? Is it genetics? Well, we know that genetics can't explain a rising population of inflammatory bowel disease. So it has to be something that's changing in the environment. And so at the University of Miami, as well as other studies throughout the world, we've looked at different factors that may be contributing to the development of IBD. And there's several. So at the end, what all of these seem to have in common is that in patients that may have some sort of genetic predisposition, there seems to be an exposure that is causing the microbiome, so the bacteria and the flora in our intestines, to act in a different way, and in a way that it creates in the intestines an inability for our gut to recognize different types of exposures. So it almost causes a different microbiome. And so what are the environmental factors that may be contributing? They include factors of the Western world. So there are, for example, increased C-sections, not necessarily breastfeeding, a lot of antibiotics, right? They have a huge impact in our flora. And a lot of studies show that, for example, antibiotics at a young age can really affect the microbiome in a way that may have some long-lasting effect and increase the risk of IBD. Now, there's other factors, for example, like ibuprofen, Aleve, naproxen. These are NSAIDs, and these can contribute, of course, not on their own, but these can contribute to an increased risk of IBD based on what's been described in the literature. Diet plays an important role. We think that a Western diet that is characteristically low in fruits and vegetables, high in saturated fats, additives, emulsifiers, that diets such as this one over a period of time, and people who are perhaps taking different hits over time and maybe have some genetic predisposition as well, they can culminate in diseases like inflammatory bowel diseases. So when we looked at one study here in Hispanic individuals and also non-Hispanic whites, we compared what's more important, genetics or the combination of all of these different environmental exposures. And what we found was that it was really impressive how much the environment, all of these factors that individually seem to be contributed, when compounded into one big score, had a bigger impact than genetic predisposition. So that is a good thing in a way, because one thing that we can tell our patients is that, if you have inflammatory bowel disease, you're worried about your children perhaps being at increased risk of IBD, perhaps there are actionable things that we can do to kind of lower that risk, right? Based on the studies that I just described. And some of that can be, for example, giving less antibiotics, only giving if it's absolutely necessary, right? So giving less NSAIDs, what I just mentioned before, less ibuprofen, less Aleve, less naproxen. So those are kind of factors that you can do to kind of ameliorate some of those risk factors. Breastfeeding, vaginal deliveries are also important.
Thank you, Doctor. Dr. Deshpande, what influence does diet have on developing IBD, and have there been studies of diets that have helped cure IBD and IBS?
Man, Kermit thought he had the doozy. So this is really the million-dollar question. And I think Dr. Dama set up beautifully the first part of that. She talked about the complex interaction between the genetics that an individual person has and the environment and their immune system. And where that environment, immune system live is in the gut, as you heard, with the microbiome. And what people don't sometimes appreciate is the largest interface between us and our environment is the gut in terms of surface area, more so than the skin. And so, and unlike the skin, which is kind of very tight cell to cell, this is intentionally open to allow for digestion. So as you can imagine, there's a huge interplay between the environment in the gut and us, which helps activate IBD. And that environment is oftentimes the diet, right? And so the components of the diet, the proteins, the carbohydrates, the fats, the micronutrients, the bacteria, have this very complex interplay. So the answer is kind of complex in the sense that it absolutely diet plays a huge role in the development and the development of the inflammatory bowel disease. The challenge becomes, how do you convert that into an answer to say, take this diet? So in celiac disease, which is also an immune-mediated disease, we know that there's a straightforward, for the most part, if you avoid gluten, celiac is treated. This is unfortunately not as simple because it's a much more complex interplay. And so I say to our patients often, I can tell you for certain that diet plays a huge role, but in 2024, I wish I could tell you this is the Crohn's diet or the ulcerative colitis diet. Now, we certainly have diets that we use that have less pro-inflammatory components. It's called an anti-inflammatory diet. We have certain types of exclusion diets that avoid certain things that activate things that are inflammatory more than others. And so we can use these as adjunctive therapies, but except in very rare situations, using just diet as a treatment, we're not quite there, except, as I said, in very rare situations in 2024. But certainly many studies about these different types of diets that can help reduce symptoms as well as reduce inflammation. And there's a lot more of that work going on both here and all over the world.
And Dr. Kerman, how does intestinal microbiome factor into inflammatory bowel disease, and are there treatments that target the microbiome?
So that's a great segue from some of what Dr. Damas and what Dr. Deshpande talked about, as the microbiome is sort of the internal environment of the gut. We have microbiomes all over our body, on our skin, in different areas. But what we're talking about here is the intestinal microbiome. And what we understand from the science is that when somebody is born, there are lots of factors that Dr. Damas alluded to that will sort of shape people's microbiome. And what happens when somebody's born, whether it's a vaginal delivery or a C-section, whether they breastfeed or they're drinking or they don't, and what other kinds of environment they grow up in, your microbiome as a baby, as an infant, is pretty durable and doesn't really change a whole lot for most of people's lives. And so that signature that people have really determines how the interplay, as Dr. Deshpande talked about, between that environment and your intestinal immune system and what it lets in and what it lets out is really developed. And so even though it is pretty durable from childhood moving forward, there are different factors that can alter it. And what we like to have in inflammatory bowel disease for our patients, once you already have it, we like to have sort of a harmonious interaction between all of the different actors within the gut microbiome. What that is going to be different for one person with Crohn's, for another person with colitis, or another person with something in between there. But we know that there are many different environmental factors that can influence how the microbiome stays balanced or how it goes into a disharmonious or dysbiotic state. And we also know that when you're in a dysbiotic state, you have a much higher risk of having a flare from your Crohn's or ulcerative colitis. So some of those factors were already mentioned. NSAIDs, so that's nonsteroidal anti-inflammatory drugs, ibuprofen, Motrin, Aleve, Advil. We know that can be somewhat harmful to the intestine, and it can cause ulcers. It can also influence the microbiome. One of the biggest factors that can influence the microbiome is the use of antibiotics. And so one of the things that we all tell our patients is to be very judicious in their use of antibiotics. There's studies out from Canada that show that children that were exposed to antibiotics at a very young age had a higher risk of developing inflammatory bowel disease later on in life. That being said, your question about are there targets for the intestinal microbiome? Well, antibiotics, directly target all of the bacteria and all of the viruses and all of the different flora that exist in the intestine. And so that is one of the earliest targets that we've had. And we sometimes use antibiotics to sort of decrease some of the burden of a lot of this bacteria when it is a burden and there is a dysbiotic state. There are other treatments that are targeting the microbiome. I happen to do stool transplants, which many of you probably have heard of, and that is only allowable without, outside of a study for recurrent C. difficile infection. And stool transplants basically are a restorative procedure that takes one person's bacteria and puts it into another person. It's very, very simple. It's a frozen sample that you literally just spray into somebody through either an enema or some kind of colonoscopy. And nowadays they have a couple of FDA-approved products that are in either pill form or in enema form. Again, only indicated for recurrent C. difficile. However, there are lots of studies, including some that have happened here at University of Miami, where some of these products are being used to see how they can affect and positively influence the intestinal microbiome in patients with ulcerative colitis. And I suspect that in the future, they will also be used for patients with Crohn's disease. We're not quite there in terms of figuring out who it's good for and what bacteria are good for which patients, but we're just scratching the surface on that, and I think it's a very exciting field. And the last thing I'll say, because Dr. Damas really is the expert here on a lot of this, is that the biggest influence on the microbiome is what you eat. And so one of the things I like to tell my patients is that, again, we like to think of the intestinal microbiome with regard to inflammatory bowel disease kind of like somebody's investment portfolio. You want to be able to deal with the highs and lows. So you want to have a very diverse portfolio. So you want to have a diverse microbiome. And what's the way to make a diverse microbiome is to eat mainly a plant-based diet. Now, that doesn't necessarily work for everyone because a plant-based diet causes lots of gas and bloating for some people. For other people, it works very well. But again, diversity is sort of the key, and how to achieve that can be very different in different people. But I think Dr. Damas probably has a lot more to say about that. I'll let you continue with the questions.
Yeah. Dr. Damas, what keeps the microbiome balanced?
Wow, that's a good question. In reality, we don't quite know, right? And everybody's microbiome, like Dr. Kerman was saying, is a little bit different. It's like it's our own little fingerprint, right, in the world that is really a history, a timeline of all of our different exposures throughout time, right? And a lot of it is primed from the beginning, from the first few years up until like 5 and 10 years are really crucial years for the development and priming of our gut microbiota. After which it's fairly stabilizes, like Dr. Kerman was saying. So there's no quite way of telling you what keeps you in balance per se, but we do know that patients who suffer from inflammatory bowel disease tend to have less balance or a less balanced microbiota. And what does that mean? It tends to change a little bit more dynamically, which really adds to the complexity of the disease and our ability to manipulate the microbiota. Now, do I think that in the future, there's going to be microbiome-based therapies that extend beyond fecal transplants? Absolutely. Do we have one now besides fecal transplants? Yes, we have diet. And so that's the way I like to tell my patients about dietary therapies, that think of it as a microbiome-based therapy, because it really is is that you're treating your gut microbes and you're trying to alter them in a way that are beneficial, anti-inflammatory, in order to ultimately have an improved effect on your barrier wall integrity or the integrity of your colon or small intestinal wall. And so there are studies that look at diet as therapy and look at the microbiota pre and post the dietary therapy. And many studies over and over continue to show, both in animal models and in human models, that the microbiome can change dynamically despite being relatively stable after youth, right? It can change with different exposures, including dietary changes. And it can change quickly, even as early as 1 or 2 weeks after starting a new diet. So I think there's a lot to learn about precision medicine and how to manipulate the microbiota. But some of the most important elements that we have right now is dietary manipulation. I think in the end, we may have a better, more precise model on how to manipulate nutrients for each patient based on their individual microbiome composition. Because I do think it's true that one size does not fit all. But right now we're using it more at large, right? For large populations, for Crohn's, for UC, and trying to work on it that way.
Thank you, doctor. We just had this sent to us, so I'm going to open it up to all three of you. Can a patient benefit from a microbiome replacement with a healthy one? Who wants to go first? Dr. Deshpande?
Sure. So I think, you heard some from Dr. Damas about the idea of what probiotics or prebiotics are. How can we adjust our microbiome? That can be done through diet, as she mentioned. There are innumerable probiotic supplements that are available through various means. And one of the challenges, of course, is unlike FDA-approved medications that go through rigorous clinical trials, there's less oversight of these. And so sometimes people use the term probiotic as if they're a common thing, but there are so many variations in which bacteria, how many, in which combinations. And though we kind of put these as a one umbrella group of Crohn's disease and ulcerative colitis, as you heard from my colleagues, there's different dysbiosis, or the kind of derangement of how certain people's bacteria, not including viruses and fungus and everything else, interact. And so, can you benefit from microbiome replacement? We know, for example, in C. diff, which you may have heard of, which is a common infection that can be very dangerous. We know that you can replace someone's microbiome very specifically. We have both rectal and oral therapies, besides those fecal transplants or intestinal transplants that you heard about, that can kind of restore your microbiome and overcome recurrent infections. Unfortunately, in the Crohn's and colitis world, some trials have shown they work okay, some trials not really. And I think that's because we're kind of overgeneralizing what an individual person might need. And so I guess the question broadly is yes. The answer is probably yes, but we're in 2024, we're not quite there to understand on a person by person basis how an individual person can adjust their microbiome, whether through a probiotic or through a diet or through other environmental factors.
So what probiotic and how much has been shown to help the microbiome, and more than others? Doctor.
So I'll take a little
Dr.
bit of that. So yeah, again, you got to be careful, as Dr. Deshpande said, with the probiotics. There are some studies in patients that had C. difficile infection, which is a dysbiotic state and very similar to inflammatory bowel disease in that way. And they divided them up into groups that got probiotics, that got a stool transplant, and that got nothing. And actually, the probiotic group did a little bit worse. And that's just one study, but it just sort of highlights what you need to be careful about with those types of therapies that are not necessarily regulated. They're only responsible for putting about 70% of what they actually say into the pill, powder, whatever it is. And the rest of it could be fillers. And those fillers may have harmful side effects. We don't really know what they do to the microbiome. So I just caution with use of probiotics. That being said, there have been a couple that have shown some benefit in specific clinical situations. Some of you may have heard of a probiotic called VSL number 3. That was shown to benefit patients in ulcerative colitis that have had their colon out and they have a pouch. That's sometimes given to patients, and it can work in some people, and it doesn't work in other people. The other things that I like to highlight for patients in terms of getting replenishing good bacteria. Again, you replenish good bacteria every time you eat, and every time you eat healthy food, every time you eat plant-based diets, other types of foods that can let's call it encourage in your intestine good harmonious bacteria and microbiome are fermented vegetables or fermented foods. We know that those can do very well. We also know that things like live active cultured yogurt also can do very well. Not all of this is in studies, but some of this, at least, it doesn't necessarily have as many of the quote unquote fillers that some of the over-the-counter probiotics that are advertised out there do have. So again, I would raise some caution. I would try to stay as natural as possible because, as Dr. Deshpande alluded to earlier, we know from large population-based trials that one of the things that leads to development of inflammatory bowel disease are some, and Dr. Damas alluded to this as well, are some of the produce foods like that have emulsifiers and sort of the fake foods that come in a box or a bag. We don't know exactly how they affect people that already have inflammatory bowel disease, but we do know that they can increase the risk of development of inflammatory bowel disease. So I try to tell people to stick with natural foods and that the best probiotics are fresh fruits and vegetables.
Thank you, Doctor. Get Dr. Damas.
I was going to echo what Dr. Kerman just said. I think he's absolutely right on that. I mean, I think that probiotics is like the wild, wild west right now, and we really don't know what we're doing. But studies do show over and over that when you go the natural route, for example, like omega-3, there's a ton of capsules that were given, right, and tons of studies looking at the role of fish oil and IBD, and those studies just continue to not show a significant improvement or signal that they actually are effective. Whereas if you look at the intake of fish high in omega-3, you actually see that there's some benefit to it. So I think that there's just much more than that what we know about diet to diet or micronutrient to micronutrient interactions and what's actually happening when we put that into a drug on its own. And so it's not the same thing. I think if you want to have probiotics or prebiotics or do something healthy for your gut, you should have, like Dr. Kerman was saying, fermented foods, natural yogurts, kefir. These things are very good for you, and eat the rainbow. Eat a diversity of different plants, foods, whole grains. And when you're in the supermarket, stay away from the middle. Go to the periphery. That's a very good rule of thumb. That's where the natural, less preserved things tend to be. And you can't steer wrong in that direction.
Thank you, Doctor. By the way, we're getting tons of questions, so please bear with us. We're going to try to get to as many of them as we possibly can. Let me open this up to the group. Can tests like a colonoscopy or an endoscopy after the microbiome, because of the prep, can you determine?
So the answer, the answer is, sorry. So there actually have been studies on this, and it is very rare for somebody with inflammatory bowel disease to get into a flare after just a regular bowel prep. For somebody that had been healthy and doing well, and then all of a sudden they get into a flare just because of a bowel prep. That being said, I don't think it is. I think those studies have a little bit of flaws in them. For the most part, a bowel prep is just going to clear out the one portion of the intestinal microbiome. As Dr. Damas alluded to, this thumbprint or this unique sort of signature that each of us has for our own intestinal microbiome is relatively durable, unless you do things to change it, like we already mentioned, antibiotics or NSAIDs, even some IBD meds that we use can positively influence the intestinal microbiome. But that unique signature that you have really stays durable beyond something like a bowel prep. There are several parts of the microbiome. There's the stool part of it, which is just sort of the luminal microbiome. There's a mucus layer that sits on top of the intestinal villi that is another part of the microbiome. And then there's the actual microbiome and the environment around the intestinal cells themselves. And a bowel prep, well, certainly alters it a little bit, but that it doesn't make the changes that dramatically.
Thank you, doctor. This is fascinating, by the way, and we're getting so many questions. We're going to get to as many of them as we can. Dr. Deshpande, I have cholanginous colitis. Is that different than ulcerative colitis, and is it treated differently?
That's a good question. So we have, just because we don't want to make it too simple for everybody, we have a kind of a bucket of inflammatory bowel diseases, and the major ones that you've heard about are Crohn's disease and ulcerative colitis. There's kind of a middle ground called indeterminate colitis, and these are all things that when you do an endoscopy or a colonoscopy or an MRI, you can kind of see some abnormality and inflammation. Then we have a group of diseases called microscopic colitis. Microscopic because if you do the regular colonoscopy, the colon may look entirely normal, but if we ever see a patient who has diarrhea with no explanation, we always not only do a colonoscopy but also take biopsies to see if under the microscope they have colitis. That's called microscopic colitis. You can't see it like you can in ulcerative colitis, and there's two varieties of that, lymphocytic and collagenous. And so, to the point of the question, it's a subset of microscopic colitis. The collagenous colitis and lymphocytic colitis have various causes. Sometimes it's a medication. You heard about this term NSAID in the past, non-steroidal anti-inflammatory drug. There are other medications that can kick this off. There's that other subtype, lymphocytic colitis, can be associated, for example, with celiac disease. And so when you have this type of colitis, the most common treatment is actually removing the offending agent if you can find what caused that. It's oftentimes that more so than a purely immunological phenomenon like you see in typical ulcerative colitis. But many times people need drugs to treat their symptoms, antidiarrheals or targeted therapy. And though not common, we will not infrequently, I should say, use the same kinds of treatments that we use in typical ulcerative colitis and Crohn's disease, like, for example, biologic agents, to treat more complicated or refractory causes of microscopic colitis.
Thank you. Dr. Kerman, is it possible for a crispier precision mediators a possibility for a cure?
Well, you're going to the latest and greatest here. I'm going to go ahead and say, of course, it's possible. Absolutely. Has it been studied yet in Crohn's disease? I know there's some sickle cell disease states where CRISPR gene editing technology has really had some tremendous success. So, to answer this question, you kind of have to go to a little bit further back. In the development of inflammatory bowel disease, as we talked about, it's a combination of genetics and environment. And can you really change the genetics of somebody that already has inflammatory bowel disease? I mean, I think that's a little bit of a complex question, and whether or not that can happen after somebody already has inflammatory bowel disease, that I don't know. And I don't know that that's something that you would necessarily want to alter at that point. But I'd love to say yes, and I don't want to. I certainly think that it is a possibility. Many years in the future, I think there's some other therapies that we'd probably see emerge prior to that. Again, the genetics of somebody really determines what their immune system and their gut immune system development happens with its interaction with the environment, as all the things that we already mentioned. But somebody's own immune system really, is developed within the bone marrow, and short of a bone marrow transplant, I don't think individual gene alterations right now at this day and age, 2024, is something that that's something that's being explored just yet. But I'm curious if my colleagues have other opinions or knowledge on the matter.
Yeah, I mean, I agree, and I agree entirely. I think it's important to differentiate. You heard Dr. Damas earlier talk about the genetic complexity of this disease, where CRISPR is an incredible technology, and I'm hopeful that in 5 years we'll be having a very different conversation about this in these kinds of diseases. But where we've seen it be able to come to a commercial product, as many of you know, is in sickle cell disease, you heard, right? A specific gene, a specific flip of one little thing called an amino acid, and is flipping, and that causes a change in a gene, which causes sickle cell disease, right? So it's a very specific monogenic thing, and meaning like really one gene that's affected, and we know where that is and how to edit it. So you take those scissors that you see in those cute CRISPR kind of descriptions, and you remove and replace. Unfortunately, you know, in inflammatory bowel disease, we thought there was first a few, then 20, then 40, then 80, then 10 years ago up to 200, and now many more genes and how they interplay and interact, not including the environment. So unfortunately, it's much more complicated in inflammatory bowel disease. I think the idea is great, and as we understand more about gene editing in complex diseases, we may get there, but certainly not on the table in our armamentarium of therapies in the kind of near future.
I want to ask Dr. Damas about some of the things that she's doing with the genetics of IBD that we know about right now in the population in South Florida that we have, because I think it's somewhat relevant to that discussion.
Thanks, David. I completely echo what you just said, Amar and David. I mean, it is a very complex disease. It's not monogenic, meaning one gene. So it's going to be really hard to use CRISPR technology when we have a variety of different, it's not even really genes per se that we have identified in IBD. We really just identified locations within chromosomes that are associated with an increased risk for developing IBD. And there's a couple of genes that we know of that play a role. So, it's not an easy disease to understand genetically. Some of the things that we've done here at the University of Miami are really, really cool, because we're contributing to helping that disparity in understanding what is contributing to the development of IBD in Hispanic individuals. So we have looked at the genetics of patients that are Hispanic all over from Latin America, and we have sequenced their genome. So we've looked at their genes. And what we have found is a variety of different things, but including that there's a lot of overlap with the genes that are known to increase the risk of IBD in non-Hispanic white populations and in Ashkenazi Jewish patients. But we have also identified certain differences that are very interesting, because they mostly have to do with not just how the Hispanic individual, not just being Hispanic, but more in particular, what is your ancestry of being Hispanic? So are you a little bit more African? Are you a little bit more Amerindian or Native or Amerindian background, like Mayans and et cetera, right? Or are you more European? And so what we're understanding about the genetics and the risk of IBD is that there may be differences in your genetic predisposition based on that ancestry. And there may be some genes that in Amerindians, patients from Native American background, for lack of a better term, may have their own unique susceptibility to developing IBD that perhaps differs from the genetics of African patients or African ancestry and that of European whites. So there's more to come on that. But we are doing a lot of the novel work here at the University of Miami because we have a very large population of Hispanic individuals with inflammatory bowel disease.
Dr. Damas, would you stay there just for a second? Because we have a question here for you. Are Crohn's and colitis the same disease or two different diseases? I have Crohn's, and it's hard to understand what applies to Crohn's as opposed to colitis.
Right, that is such a great question, and I think it's so relevant. Okay, so I'll start by saying that by definition, there are two different diseases. Crohn's disease involves the small intestine, can involve the small intestine, the colon, or anywhere in the GI tract, including in the perianal area. Now, colitis or ulcerative colitis only involves the colon. Can there be, and now this is where it gets a little bit more gray, can there be Crohn's colitis, so only in the colon, but you have Crohn's disease? Yes. And so there can be a little bit of overlap between the two diseases in the location, but this is where it's really in the eye of the doctor to recognize which disease type it really looks more like. Because on the biopsies, there's a lot of similarities between the two. So we guide ourselves by how it looks on endoscopy and also by the location of the disease. That said, I think that it's important for patients to recognize that the treatment for both of them is very, very similar. I mean, sometimes there's drugs that are approved for one medication for Crohn's, for example, before they're approved for ulcerative colitis, but it's really only a matter of time before they're also approved for ulcerative colitis. So, and that really comes from the nature of genetic predisposition and the similar microbiome issues that are taking place. And there's a lot of overlap between these two cousin diseases. And it may even be that later on we find that there's different types of inflammatory bowel diseases that, as we get better about recognizing an individual footprint of microbiota footprint of each patient, that we may be able to clump these diagnoses in a different way. But for now, the way that we're really categorizing them is what I just mentioned: location, presence of complications like fistula or more Crohn's, and then how it looks on endoscopy. Now, the treatment is very similar between both diseases. We often have the same medications. It really comes more when it comes to surgery that we really have to make some distinctions between the two.
Thank you. Dr. Deshpande, for a 77-year-old New Jersey male with a 60-year history of a small bowel Crohn's and resection and a stricture plasty surgery history, is Skyrizi and Entyvio best treatment? What is the best treatment, Entyvio or Skyrizi?
Yeah, so these are pretty nuanced, specific questions that unfortunately take a little bit more kind of question and answer with an individual patient, but it does highlight the general categories of medications. I'll say to your specific question, with small bowel disease, it depends on how active it is, where it is, what the labs look like, what the comorbidities or other diseases or illnesses are. In someone who's older, you might prefer one drug over another. Different patients have different thresholds for safety versus efficacy. So it would really be hard to kind of make an individual patient comment on that. But I think it's a nice segue, if it's appropriate, to just, you talked about Skyrizi and Entyvio, and these are two of a few common classes of medications that we can certainly get into in greater detail, but they really, one of which kind of blocks some of the inflammatory molecules called cytokines, something like Skyrizi, in which these things that are upregulated in some of our inflammatory bowel diseases like Crohn's and ulcerative colitis as well. It can block those molecules from kind of turning on inflammation, and that makes people feel better and decrease inflammation. Where something like Entyvio actually blocks some of our cells, our immune cells called lymphocytes, from leaving the bloodstream and getting into the gut, where they can kind of wreak their havoc and cause inflammation. So I wouldn't want to necessarily completely commit to that without knowing more information, but both could potentially be used. They're both approved for Crohn's disease, and can be used depending on the right situation. And then there's, of course, other classes of drugs. People may have heard of like the Remicade and Humira and Cimzia and Simponi class, which blocks another inflammation molecule called tumor necrosis factor, or TNF. And in a very exciting way, there are now everything we mentioned were all IV or subcutaneous formulations. And we now have, over the past few years, oral medications as well, things that block another pathway. They're called JAK inhibitors, and another pathway that traps these same immune cells in the lymph nodes. And these are now oral medications in addition to our biologic medications. So it's really expanded our armamentarium of treatments.
Thank you, doctor.
And
Yeah.
Dr. Deshpande, I sort of want to elaborate on that a little bit, because I think you touched on a lot of good points. I think to answer the attendee's question, the medication that is right is the one that is safest and the one that works. And that doesn't always happen with the first try. Sometimes it happens with the second or third medication that comes along. But that's really where our personalized medication is these days, which is the safest for this particular patient, and which one targets the best kind of disease that they have. And I will say one other thing about this particular question is that there's inflammatory disease and there's stricturing disease. And sometimes inflammatory disease can turn into stricturing disease. And one of the things that we've learned over the years is that inflammatory disease is much easier to treat than stricturing disease. and you have to use different tools to treat different kinds of disease. Oftentimes with stricturing disease, it requires surgery in addition to medication. Sometimes even though it's just inflammatory disease, it still requires surgery because they're not responding. But the answer is the medication that works the best. And the good news is that there are a myriad of other options that Dr. Deshpande just talked about that are all in the pipeline for all of these different types of diseases, including stricturing disease, which we're just sort of scratching the surface on now.
Thank you, Doctor. Dr. Damas, can you speak to the science on Crohn's and pregnancy? I have Crohn's as an adult and having children. And then more specifically, does Crohn's or certain medications influence AMH levels or the ability to become pregnant?
That is such a good question. I'll start by saying that many women with Crohn's disease or ulcerative colitis avoid pregnancy, thinking that they can't have kids because they have Crohn's disease and ulcerative colitis, and that is absolutely not true. You can have a very normal pregnancy and on medications if you have Crohn's disease or ulcerative colitis. So that's one factor. Now, when we're looking at a patient getting ready to become a mother, we have these beforehand, during the pregnancy, and thereafter. And I can tell you that the number one factor that contributes to pregnancy-related complications or a premature birth or a small for gestational age baby is having active inflammatory bowel disease. So having active Crohn's disease or ulcerative colitis during the pregnancy. How do we prevent a flare-up or active inflammation during the pregnancy? We do not stop the medications that patients are on pre-pregnancy, and we try to set ourselves up so that when patients are planning to become pregnant, they are in remission. Not just in clinical remission, but in complete remission. We've looked at them in a colonoscopy, ideally, before we looked at their stool for no inflammation, and we have achieved complete remission. That gives the best bets of having a normal pregnancy for both mom and for baby outcomes. And so now across the board, all European American guidelines recommend that moms who are on advanced therapies such as Humira, Remicade, vedolizumab, so Entyvio, Skyrizi, Stelara, I'm naming the ones that have been the most studied, that they continue throughout the pregnancy and that they do not stop these medications. Now, to answer her other question about which medications do we avoid during pregnancy, we avoid medications like methotrexate. That one we definitely avoid because there can be problems with baby formation or even just being able to get pregnant from the male side. So we stop that medication about ideally 3 months or so before the pregnancy. If you are taking allopurinol in combination with mercaptopurine or azathioprine, that's another medication that we stop. We also don't have a lot of data on patients who are on what we call JAK inhibitors like tofacitinib and upadacitinib. So it really is about a conversation to have with your doctor if you're planning to become pregnant, just because, not because there's just not enough data on patients who are on that medication who are pregnant. So we try to not put patients who are childbearing age on that medication, but sometimes we just have to because we have to control the disease and it's the most important thing in the end. And the other medication, which is ozanimod, is also not that well studied in the setting of pregnancy. So we also don't recommend that one, or at least we need to have a conversation with the patient just because there's not enough data. But for the most part, if you're on any of these other biologics, on mesalamines, you can get pregnant and you continue the medication throughout the pregnancy.
Thank you, Doctor. I'd like to open this up to the group. Can artificial intelligence help with finding the fingerprint of what type of someone's microbiome by taking the DNA or a sample of the microbiome so that the right therapy or probiotic can be a treatment given?
Well, I'll tell you that it's not per se artificial intelligence, but machine learning models that we use in statistical analyses. In a way, so to speak, is artificial intelligence because it's a way that gets a lot of data together and tries to interpret it in a way that makes the most sense based on statistical signals. And we're already starting to do that. But that's my take on what, trying to make sense out of all the different types of what we call metadata. And I think that there's a lot of future in that from a research standpoint.
Any
Yeah,
doc-
that's I would
Oh, go
I would
ahead.
agree with that with what Dr. Damas said. And in addition to just to add that there's not quite an answer for which probiotic would work for which patient. It would be nice if it was as simple as, well, this patient is missing X probiotic, so you can go out and buy this, or X bacteria, so you can go out and buy this probiotic. There's just too much variability in what's out there on the market and how it actually translates to an individual's intestinal microbiome to really achieve whatever the balance is for them, which is also another thing that we don't know.
Thank you, Doctor. Dr. Despante.
Yeah, I would just say that I think it's such an important question, right? Because you can't ask anything in any context without someone asking about AI appropriately. And machine learning, as you heard, is kind of a subset of artificial intelligence. And I think the key, putting aside like generative AI, like you hear about ChatGPT and all that, creating prose, the critical aspect of these parts of it, artificial intelligence, aren't so much creating new information. That eventually is going to be what AI does. But what it does is, and you heard Dr. Damas allude to this, take huge swaths of information and be able to comb through it in a meaningful way. But that still requires the input, right? So we can say, how can AI help us in IBD? And certainly there are ways in which it can, but it requires having a meaningful input that then that process can then use to comb through to come up with meaningful output. So I think that's what we're trying to still work through is what are those inputs? How valuable are they? And how can we meaningfully put that in? I think over time, you'll have these generative AI opportunities to kind of also come up with things, but that's kind of where we are now in the space within these kinds of complex interplay diseases.
Dr. Despande, stay right there. Are there any cultures or countries or zones that tend to have less IBD?
Yeah, it's a great question because for almost any disease, what people are trying to do in their field is show a map of the world and show where that is more prevalent. And so it's a very interesting idea for many autoimmune diseases. In fact, if you look at there are studies from about 10 or 15 years ago of this, as in the 20th century, as infectious diseases sharply declined with the advent of antibiotics and hygiene, things like tuberculosis and others, and influenza and many other things. As those went down in a reverse, exactly opposite direction, you saw a lot of autoimmune diseases, multiple sclerosis, asthma, Crohn's disease, etc. And so this is something that has been termed the hygiene hypothesis. And so when you look at a lot of autoimmune diseases, and if you take a picture of ulcerative colitis or Crohn's, particularly these inflammatory bowel diseases, what you a lot of times see in a snapshot of the world is those places that you perceive to be more industrialized, more kind of economically advanced, better access to hygiene and clean water, tend to be places that there is more autoimmune disease, and these diseases are no exception to that. Even within countries that are developing, and I'll take for example, the economically developing BRIC countries, Brazil, Russia, India, China. Just as a way of highlighting my culture, like if you look at a map of India, India had very little inflammatory bowel disease several decades ago, but where it's rising rapidly is not so much in the rural or the villages, but in the cities in which there's more of a kind of the hygiene hypothesis, if you will, more access to clean water and sanitation, et cetera. And so I wouldn't say so much that it's geographic zones, like certain diseases are more common in certain parts of the world for certain reasons. It more has to do with that kind of industrialization. But the reality is that the world is becoming global, and industrialization is becoming a worldwide phenomenon. And so I think it's important to not pigeonhole, to say just because someone is from a country that may be perceived as less industrialized, they can't get this disease, and we have to think about it in everybody. But if you do look on the whole, kind of societally, it tends to be highest in places that are more kind of, if you want to call it, economically industrialized, and with that kind of hygiene hypothesis.
Anyone else want to weigh in?
Yeah, absolutely right. I mean, I'll mention that we did a study a couple of years ago looking at the incidence and prevalence of IBD, so Crohn's disease and ulcerative colitis in Colombia. And so we used large government data that was available to us to look at, well, what is the incidence and prevalence and how does it differ by regions in the country? And what we found, and this was in collaboration with several Colombian doctors that treat IBD, what we found is that, and perhaps not surprisingly, based on what Dr. Deshpande was saying, that the incidence of ulcerative colitis and much less so, but present still, Crohn's disease, was higher in urban areas, particularly, for example, along the Andes Mountain that happens to have a lot of cities, dense cities in Colombia. And so it really, I think it's more about those pockets of more urban development or more developing, Western developing cities that if you go to, for example, the capital of Colombia, you have the same available fast food restaurants that you do here. If you go to Puerto Rico, it's almost the same thing as Miami, and they have a very high prevalence of Crohn's disease. And so, I think that the world is increasingly becoming smaller and more homogeneous in that way. And I don't think that there's a lot of difference in terms of over time. What we're going to see is that the prevalence is going to increase throughout many countries.
Well, thank you all for where this hour went. I don't know because it's been an amazing hour. Thank you to all our panelists who have helped us explore the groundbreaking research efforts on pancreatic cancer. Thank you all for watching. And remember, it's always about the you.